So welcome to the very first edition of our webinar series at Somnix Health, the maker of iNAP. And today we're very happy to have Dr. Lennon as our guest. And so Dr. Lennon is a certified sleep physician in Cordova in Tennessee. And he has his practice over there at the Neurology Sleep Clinic. You can see here all his credential. He's also a clinical advisor for Somnix Health and has been with us for about a year now, I think so, right? So, so we're going to start right away. We're already a little bit late, but the first thing is, Dr. Lennon, first, thank you for being the very first host of those webinar series. Could you please briefly describe what is a negative pressure for the audience?
Sure. Negative pressure is not that difficult to understand. I mean, we're all basically used to positive pressure with the use of CPAP. We have the flow of air going into the nostrils, down the throat to basically blow open the airway from behind, to push the palate forward, to push the tongue forward. Negative airway pressure is also using a pressure gradient, but rather than pushing the tissue from behind to open up the airway, we're actually pulling the tissue forward towards the front of the mouth. So with negative airway pressure, we're helping to suction the soft palate anteriorly to pull the tongue towards its natural resting position closer towards the teeth rather than pushing it from behind. As you can see, it uses a simple mouthpiece that inserts above the tongue and below the palate and creates a vacuum. And this vacuum helps to maintain the tissue in that anterior position to open up the retropalatal and retroglossal space so that there's plenty of room for air to flow in and out.
Well, thank you. I'm actually sharing my screen where you can actually visualize what Dr. Lennon just described. Can you tell a little bit more about the level of negative pressure, because people are used to the positive pressure on a flow device like a CPAP, but negative pressure is something a little bit different in terms of physiological feeling, I would say, for the patients.
Sure. I think a lot of the difficulty people have with CPAP or BPAP is the novelty of that positive pressure. It's not something that we're used to experiencing in our airway at any given time. Whereas with negative airway pressure, the amount of pressure utilized with a device like the iNAP is substantially smaller than the amount of pressure that we're used to experiencing in other scenarios. For instance, when we swallow, we're typically having a negative pressure gradient of somewhere between 200 and 250 centimeters of water. Whereas with a device like the iNAP, this is using about 53 to 54 centimeters of water negative pressure, which is also a lot smaller than, say, a nasal aspirator and substantially smaller. We're talking about 4 to 5% of the pressure gradient used with a dental suction device that you might see when they're trying to keep your saliva from pooling in your mouth during a dental procedure.
Great. Okay, well, thank you for that quick introduction on what's negative pressure. Of course, if you have questions, please you just write in on the Q&A and we'll address them. And if we cannot address them at the end, we'll follow up definitely with email. But I want to, go back a little bit to your own experience, Dr. Lennon. Why were you interested in alternative to CPAP in general and iNAP in particular?
I think for anyone that's been treating sleep apnea patients for any amount of time, we all recognize that, we fail a lot of our patients, right? I don't think there's going to be a replacement for CPAP anytime soon as the gold standard of treatment. We know that it's highly effective. It works for a great number of people, but we have a hard time getting those people to stay on CPAP therapy, let alone to be able to adapt to it in the first place. And so we have a tremendous need to treat a substantial minority, if not the majority of patients who are not able to tolerate CPAP or BPAP with some alternative mechanism. And so we have oral appliances, we have different surgical interventions, hypoglossal nerve stimulation is growing certainly as well. But I was interested because, I first read about the predicate device, the Winx, about a decade ago, and just, really curious about the mechanism. It's sort of combining a little bit of, anatomical change and in a physical barrier with this particular mouthpiece that they had. And unfortunately, never got the opportunity to try the device myself with any of our patients. And so, when we first saw the iNAP at the sleep conference several years ago, very, very, very interested in it. And so, as soon as it got its FDA clearance, nearly 3 years ago now, very, very excited to be, some of the first practices in the country to be able to utilize this therapy for our patients.
Well, thank you for that. And since you have a lot of experience with iNAP and with all your patients, who would be a good candidate for iNAP? Because there are so many different cases and so many different types of patients, and there's no one treatment that fits them all. So you got to be doing some kind of a triaging or at the beginning. So what would you be your own criteria to figure out, okay, this patient might be more successful than another patient?
Yeah, so broadly speaking, this is FDA cleared to treat sleep apnea in adults, not in children or adolescents. So that's that's part of it. It is basically the only other treatment other than CPAP that's FDA authorized to treat all levels of severity, mild, moderate, and severe. So there's no restrictions, say, based on AHI, which is really good, like you might see, say, with oral appliances or hypoglossal nerve stimulation or some other interventions. However, based on the mechanism, we know that we're pulling tissue forward to open up a physical obstruction. And so unlike, say, CPAP, we're not likely to get any sort of therapeutic benefit with central apnea. And so in general, we're not using this device at all for anyone with any degree of central sleep apnea. I know for other treatments, they might say as long as your central apnea index is less than 25% of your AHI, then it's fine to use this intervention. In my practice, basically, if someone has any degree of central apnea, we're not using iNAP. We're using it exclusively for obstructive sleep apnea. That's a big key. Another thing, we do have some data showing who's likely to succeed and who's likely to be a non-responder, and we know that, like with a lot of treatments, anatomy plays a really big role. So, for instance, the larger somebody's BMI, the less likely they are to be a responder to the negative airway pressure. We also know that the more tissue there is in general, such as redundant soft palates, if they have an enlarged tongue, that they tend to be less likely to be responders. If they have a higher Mallampati grade, they're less likely to be responders. And similar to what we saw with hypoglossal nerve stimulation, the greater the contribution of concentric collapse versus, say, tongue and especially palatal contribution to obstruction, the less likely they are to respond. So using some of these anatomical features, I think helps quite a lot. But certainly, just like with any therapy, the patient's motivation plays a really big role. So if there's someone who is kind of on the fence and they're not really sure what they want to do, then we generally try to stay away from something like the iNAP. But there are a lot of people who are highly motivated to treat their sleep apnea, that are interested in something that is small and compact and simple to use. There's literally just one button to turn it on and off. And so when they're motivated, they tend to do a whole lot better.
You did mention something that I think is important is patient motivation. Obviously, not every patient will be successful with iNAP from the very first night on. And it will take some motivation, some training of the patient. So how do you introduce iNAP and how do you set expectation to those patients? How do you tell them, okay, this is what's going to happen first, and you might be experience this effect or this effects, and eventually you can become successful?
Yeah, I mean, part of it, we lay the foundation even with an initial evaluation. We're seeing somebody for snoring or for daytime sleepiness, letting them know that, if a study were to confirm something like sleep disorder breathing, that, we do have a wide variety of different treatment options available to them. We have our gold standard of CPAP, which again is not going away anytime soon. But if for whatever reason they don't tolerate that, or it's not going to work for them, or they would decline that therapy, that there are lots of other options, including negative airway therapy. So we're sort of introducing that idea, from the get-go to sort of plant that seed. If somebody has elected to go forward and really wants to start something like iNAP therapy, then we try to lay the ground by demonstrating for them how it works, how easy it is, where you basically just put the mouthpiece in, you hit the on button, and then you're ready to go. We show them how the mouthpiece fits in, like where you're likely to feel that material, where you're likely to feel the pressure gradient, how easy it is to break that seal, because again, we're talking about like a quarter the amount of suction with a usual swallow. So how easy it is to break that seal if you have to open your mouth or talk or do anything else, and how simple it is to get that seal back together again. And you rest your tongue, and then within a matter of seconds, the tongue is pulled back up towards the palate, and that seal is recreated, and the pump turns off once again. So we, the actual experience, we try to prep them for that itself. We discussed the simple maintenance of the device. It's quite interesting that we have these little sacks to fill all the saliva. Some people are like, well, if you're going to have, because their experience might be, say, something like the dentist, where you're just sucking out saliva and juices from the mouth, and that can gross people out sometimes. And they're like, well, am I just going to have this big box full of my spit next to the bedside every single morning? And we have these nice sanitary little pads that soak up all the saliva. And in fact, even though the pads are quite small, there's actually very, very little fluid that actually gets into there. And so it's really quite easy to maintain the device and to put in a new pad for the next morning. So we try to introduce that portion of it as well. And then we want to make sure that the patient is taking advantage of all the tools, say, that are available within the app as well. There's different ways that we can modify the speed at which the device is achieving the target negative pressure. And then, of course, off-label at this point as well. But we as clinicians are able to adjust the degree of negative pressure. So if that negative 40 millimeters of mercury or negative 54 centimeters of water, the standard authorized degree of negative pressure, if that's not working for the patient, we do have the ability to decrease that pressure to a greater extent, or to soften that pressure if the patient's having a little bit of difficulty initially adjusting to the therapy as well.
And so in order to be able to make the decision on how to change those parameters, or how to better coach the patient, what type of feedback do you get? What type of feedback loop are you using in order to understand how the patient is actually doing with their treatment?
Right, and thankfully, as we're used to in most of our interventions these days with the devices, that there is a dashboard, there's an online portal where clinicians can log in and see how their patients are doing. Now, the main difference, say, between sort of our prototypical CPAP dashboard and something like the iNAP is that with CPAP, we also are getting not just data based on the patient's use, but some feedback on the efficacy. And because iNAP is not giving airflow and not measuring airflow, we don't have a direct measurement of efficacy from the dashboard itself. What we do see is when the patient is using the device or not using the device. We're also able to see the degree of seal that the device is able to keep. So for instance, you put the device in the mouth, you turn on the pump activates, and then it creates the seal. And then once the seal is there, the pump actually turns off. This is the eye of iNAP, is this intermittent nature of the pump. So once it reaches that negative pressure gradient, the pump turns off. And so as soon as that seal is broken, the patient opens their mouth and move around, or something happens to break the seal, then the pump turns back on until that seal is reached once again, and then the pump turns off after that. And so we can get a sense of how well the device, the mouthpiece, is staying in and how effective it can be based on that degree of seal. And so we really like to see at least 85% seal, and ideally, well above 95% of the time, where the pump is actually turned off and the seal is maintained. If we're seeing that they're breaking the seal quite a bit, the pump is constantly having to turn back on because the mouthpiece is not staying in place, that's when we'll make some interventions. And so this could be something as simple as helping the patient adjust to it, a desensitization, just like we would for CPAP, having them wear it while they're awake a little bit during the daytime. It could be doing some oral exercises, for instance, basically trying to suck on the little straw that's part of the mouthpiece can help adjust the tongue into the right position to really get optimal suction and vacuum of that. And then we can also adjust the pressure. So for instance, if the seal is constantly breaking because maybe the patient is heavier, they have more redundant tissue in the airway, and the tongue is heavier, and it's just harder to maintain the position of that tissue with that very, very small negative pressure gradient that we're having, then maybe just bumping up the pressure gradient can help maintain the seal a little bit better. And so, using that data on the dashboard, that we can make these kind of simple interventions in these first several nights after the patient starts their therapy.
That's great. We had quite often our patients saying, what's my AHI? How do I measure that? Because a lot of them actually are failed CPAP patients. And so they are actually, there is a solution, as you just mentioned, iNAP cannot measure like an AHI on a CPAP as a resistance, but actually we do use some ring oximeter from other companies, but those data are integrated also into the app, the phone app. So do you also look into those ODI information that for those patients who have both the iNAP and a ring oximeter?
We tell our patients about this. So it's interesting. Actually, we don't have a single patient that has one of these oximeters. But you're right, that there is a way where we can get not necessarily an REI or an AHI or an RDI, but an ODI, an oximetry desaturation index, because of the ability to link some of these consumer grade pulse oximeters with the iNAP Lab Plus, the app that accompanies the iNAP physical device, which again, the patient can use the device without needing, they don't need the app to use the device, that can be done independently. But if the patient is using the app as well as the device, then now they can actually sync the data from a pulse oximeter, whether something like a ring or fingertip-based oximeter, and then the iNAP app, the iNAP Lab Plus, will calculate an ODI for that patient on that particular night. And what's great is that within the dashboard, we can see across the night, similar to what you might see what the leak might be or what the pressure gradient might be. We can see the same thing for the iNAP. What is their negative pressure? When were there breaks in the pressure? When the pump had to turn back on? And you can also look at that tracing exactly for the ODI as well. What was the oxygen saturation? When were there any drops in the saturation? Do we see, are they having any desaturation events when the seal is maintained, or are they exclusively having events when the seal is broken and the pump is turned back on? And that lets you know, is the degree of movement we're having of the tissue, is that sufficient to treat their obstruction? And maybe any residual ODI that might be there is simply a result of the seal being broken. We just need to do better at maintaining that seal, or do we need to actually move the tissue a little bit further? Because even when the seal is maintained, there may still be some desaturation. So that kind of feedback from an ODI perspective, not necessarily getting an AHI or an RDI, but can certainly inform us on the effectiveness of the therapy ongoing, especially since we have the ability to look at that tracing, minute to minute, second by second, both for the pressure gradient for the iNAP as well as for the oxygen saturation.
Great. There's one important factor that we need to talk about, obviously, because as a patient has to keep their mouths closed around the oral interface to keep that seal that you've talked about, then the patient will have to breathe through the nose. So how important is nose breathing to the success of iNAP? And what happens when a patient comes to your office, is a good candidate for iNAP, but you realize that he has some difficulties with his nose breathing?
Right. So obviously, the way that the mouthpiece stays in place is by actually sealing off the oral cavity so that you can actually create that vacuum. And so in order for iNAP to work, you have to be a nasal breather, right? So anyone who suffers from allergies, occasional congestion, sinusitis, or chronic congestion where they're just having a great deal of difficulty breathing through their nose, they might face some additional challenges with success for the iNAP because of the requirement to be able to breathe through your nose for this. And so if that's the case, we may try working on some different interventions to improve their nasal breathing before moving to the iNAP. And so in our practice, there are several ways to go about doing this. We know that just nasal breathing begets more nasal breathing, right? So the more you can avoid mouth breathing, the better and more effective and easier it becomes to nasal breathe as well. And so, just having those kind of reminders for the patient throughout the day, it provides a very minimal degree of intervention to help improve their nasal breathing. Of course, depending what might be going on, we might also recommend something as simple as a nasal saline rinse, such as a neti pot or just a generic saline spray. Depending on what else may be going on, we could be talking about antihistamine sprays, sometimes decongestants. That's more of a trial, because we all know how problematic something like chronic use of Afrin can be. There are other devices that can be helpful as well. We sometimes recommend a specific device for a patient, which uses vibration to help clear the airway a little bit to release some nitric oxide, and that can improve nasal breathing. And to help for patients who are getting ready to adjust to the iNAP specifically, there's actually a really good practice device called the iBreathe, which is essentially just the mouthpiece for the iNAP, but without the tubing attached to the suction itself. And with this, they can get adjusted to the sensation of having the straw in the mouth between the tongue and the palate, of having the little flange around their teeth, between the teeth and the lips, and getting adjusted to the sensation of, creating that suction with a swallow, getting the tongue into the resting position, and practice breathing through your nose. For those that have a more narrowed opening at the nares, nasal valve issues, that there are nasal valve opening procedures that can be done, either with an ENT or with a pair of nasal dilators. For instance, the Z-Bud is a great way to do that. And so, all of these different interventions, medications, myofunctional therapy, breathing exercises, devices, they all work to help the patients achieve an easier time breathing through the nose, so that when they're asleep at night, being obligate nasal breathers with the iNAP in place, that they're able to successfully breathe and maintain that patent airway.
Yeah, you did mention a number of solutions here, and I'm sharing here my screen. Can you see the screen? Yes, I'm sharing a kind of a toolbox for physicians where we can. Let me make sure.
Yeah, I can't see your screen. Okay, there we go.
Okay, so what we can share, we have a toolbox for physicians actually to help the patient become successful, like Dr. Lennon explained. So first, it's on the app, that's a device setting. We have a different ramp up speed for the pump to achieve the negative pressure. We have also different pressure settings. They're still off-label right now. We have the nasal dilator called Z-Bud that's already available for our patient. It's just like a very comfortable tube that people even trim to adjust to the geometry of their nostril, that really increase the feeling of nose breathing. The tongue posture training, that's to be used only while the patient is awake. It's the shape and size and material of the oral appliance, but with a block port. There's no tube with a vacuum here. We have the different oximeters that we use quite often with our patient, and their data are actually automatically integrated with our data as well. And we also have proposed a protocol even for the physician and the patient to eventually be successful. Maybe we can go quickly through that, because it's
sure
that we are bringing in as well as a tool, as a help for the physician to help their patient go to success, achieve success. So maybe you want to comment a little bit? I know that you talked a little bit about it, the big 3 steps.
Right, and I think, for focus on nose breathing, this really goes for anybody, no matter what treatment they have for sleep apnea or snoring. We know that mouth breathing alone actually increases nasal congestion. It increases nasal resistance. We know that mouth breathing also leads to more instability of the breathing pattern, more likely to achieve things like periodic breathing or Cheyne-Stokes types of breathing if we're breathing exclusively through the mouth versus through the nose. And so no matter what intervention they're on, we know that nasal breathing is clinically superior for all of our patients, especially those with obstructive sleep apnea. So whatever we can do to emphasize healthy nasal breathing, I think is going to be really important. And so whether it's essentially a practice device like the iBreath that they could utilize, tongue posture exercises as in myofunctional therapy, medication interventions, whether they are antihistamines or decongestants or anticholinergic medications to help relieve some of the congestion and that might be there in the nose, Or of course, we have our wonderful colleagues in ENT that are more than willing to always help us with these types of patients with both surgical and non-surgical interventions to improve nasal breathing. That is their bread and butter, and we're very grateful to have them as part of our team. Now, once we're able to achieve satisfactory nasal breathing, then really the focus is on how can we maximize and optimize the seal of the negative pressure gradient. And so there are different ways to do this. We can, again, just with desensitization, it can help quite a bit, just like with CPAP. We know that chin straps is something that we recommend a lot for patients because that can help to maintain mouth closure, to help maintain the seal itself. We might even be adjusting the negative pressure gradient to help optimize that seal. And then once we get there, then we're starting to focus on the rest of the outcomes. And so, if they happen to have one of these companion devices of a pulse oximeter, looking at their ODI that we might see on an ongoing basis, if we have a willing bed partner to give us feedback on the degree of snoring, of course, the patient's always going to give us feedback on the quality of their rest, the quality of their wake as well. And then typically for our patients, what we're doing is sometime between 30 and 90 days, give or take, after starting on their iNAP therapy, is that we are repeating a home sleep test to get a better gold standard assessment of what is the degree of any obstruction they may still have, what is the clinical grade ODI there, what if, depending on the HST, what is the quality of their sleep now that they're utilizing the iNAP therapy as well. And so, and then of course, just like with any long-term therapy, similar to our CPAP patients, we continue to monitor them in an ongoing fashion. We're just not, say, repeating sleep studies on a regular basis for these individuals once we have established that they have a therapeutic effect.
Thank you. So I know that some of our patients as well are wearing, while they sleep, a night guard, or some have an Invisalign, some have braces as well. Because we have the oral interface as well that might interfere with those, what would you suggest? Have you have experience with this type of patients?
Yeah, I think it really depends on the specific nature of the of the oral device. So for instance, braces or Invisalign are unlikely to cause any major interference with the ability for the iNAP to function very well. If they're using an oral appliance, say like a mandibular advancement device or an appliance for TMJ, for instance, that can be a lot more challenging. I'm a chronic bruxer, and so I wear a bite guard every single night. And I've had many different versions of bite guards, and some of them are really large, and some are quite small. And so the one that I use right now, basically just a couple of small platforms between my molars, and so there's still plenty of space to allow for the passage of the straw to go between the teeth, above the tongue, and below the palate. Whereas some other devices, whether for bruxism or for snoring or for anything else that a patient might be utilizing in conjunction or wanting to use in conjunction with the iNAP, might create a physical barrier that would prohibit the passage of the straw through the teeth. So it really depends on the specific device itself, whether it could be utilized with the iNAP or not.
Okay, so it's on a case by case. So it's not a contraindication. Wearing an Invisalign
exactly.
or a mouth guard is not a contraindication to.
Invisalign absolutely would not be a contraindication, and a mouth guard would really depend on, probably most mouth guards are not going to work very well with the iNAP, but there may be some that have an opening that would allow the passage of the straw to go through.
Got it. Okay. We can open some question, also a Q&A session with the attendees. And I don't know if my colleague Parker, if she's on.
Yes, I'm here.
Yeah. Do you have any question that you got also from the people
Yeah,
signing up?
we did get one. Let's see. In the chat, there is one that is, what is % of efficacy in comparison to CPAP, Inspire, dental device, UP3? Do we have an answer on the % of efficacy in comparison to those? That was put into the chat.
Sure. Yeah. The answer, of course, is relative. There's no direct head-to-head comparison here. With the predicate device, the Wings, there was a meta-analysis of 4 or 5 studies, and the degree of improvement in the AHI was about 63%. and so, pretty good. What we see with oral appliances, mandibular advancement devices overall is comparable, right? About 60 to 70% improvement in AHI for the most part. It starts to go down if you include a lot of patients with severe sleep apnea, but certainly in that mild to moderate group, comparable degree of improvement with the iNAP as you would get with an oral appliance. With Inspire, for their 5-year registry data shows, of course they have, in the sleep world, we tend to be focused on an AHI under 5, sort of an effective cure. But of course, they're really talking about the share criteria of at least 50% decrease in the AHI, as well as an AHI under 20. And with that share criteria of a responder rate, the responder rate with the hypoglossal nerve stimulators is about 64%, give or take, so pretty similar. And so we also see, similar to the responder rate, that the percentage of improvement in the AHI is nearly identical as well, right? So most patients with hypoglossal nerve stimulator are also achieving somewhere in that ballpark, 60 to 65% or so decrease in their AHI from baseline to follow up, even after 5 years. With the iNAP, we have a few studies, a couple of small pilot studies where the relative improvement at AHI was a little bit smaller. That was actually with the predecessor device to the one currently authorized here in the U.S., which is technically the iNAP 1. These pilot trials were with the iNAP Lite, so a slightly different device. But with the pivotal trial for the iNAP 1, we have about a 73% reduction in AHI and a similar percent reduction in the ODI. On top of that, while they weren't...
Yeah, sorry,
yeah,
we're sharing the
result
on the screen right now for that pivotal study, yes.
So this responder rate of 75%, that is the share criteria, right? So that's a 50% decrease in your AHI as well as an ending AHI less than 20. So overall, I mean, for these studies, there was the clinician, the CGI had only about a 3% non-responder rate, excuse me, for the iNAP, which is pretty low. About 9% with a minimal to slight response, and then 3/4 of them with a significant response. Some of us would be satisfied going from an AHI of 32 to 8. Of course, there's a number of them that went from from moderate or severe all the way down into the normal range. And depending on whether the patient started with mild, moderate, or severe sleep apnea to begin with, each of them saw a nearly identical relative reduction in their AHI. So each severity group, again, saw about a 72 to 73% reduction in their AHI from baseline, which is really encouraging.
I might mention that on that particular pivotal study, the pressure setting of the iNAP was at its minimum level. It was at 53 centimeters of water. Now we have other studies that we submitted to the FDA where we can really increase, and as you mentioned before, Dr. Lennon, we can increase almost fourfold or more than that, and has a much higher impact on those patients.
Right. So for instance, among these 8 non-responders, there's an extension of this trial where they all went through basically an iNAP titration, where they were sleeping with, undergoing a PSG, and during the PSG, the negative pressure gradient was gradually increased until that AHI had come down significantly. And so among all those individuals who were initially non-responders at the set fixed negative pressure gradient of negative 40 millimeters of mercury, which is negative 54 centimeters of water, that as that gradient was increased, their AHI came down just as, not everyone responds to a CPAP of 4, right? And so for most people, we have to titrate that pressure to get close to this sort of personalized medicine of having, a prescription that actually matches the patient's need. And the fact that, sort of a rubber stamp of negative 54 centimeters of water works for 75% of individuals is a really good starting point, but that's certainly not the end. There is the ability, of course, off-label at this point, but there is the ability to adjust that negative pressure. So those who don't respond substantially enough to that initial pressure, that can be adjusted to bring their AHI down even further.
Well, thank you.
So again, no head-to-head comparison, but at least we're talking about the same ballpark of degree of reduction for all these alternatives, oral appliances, hypoglossal nerve stimulators, negative airway pressure, somewhere in this ballpark of 60, 75%, give or take, relative reduction in the AHI from baseline.
Great. Thank you, Dr. Lennon. Parker, do we have any other question that we might have received also by email?
Yes, we do. So Dr. Lennon, once you have a patient that asks you about iNAP or they're interested in it, what steps do you follow? What does it look like from there for you to talk to the patient about iNAP and then prescribe it, and from there what you do?
That's great question. So we're a little bit unique that in our clinic we also have the clinic, the sleep lab, and DME capability. So we are actually distributing these devices ourselves. For the patient, there are multiple options in terms of getting access to treatments. Of course, they could go to the iNAP website and they can sort of order it online there as long as they upload a prescription for it. There's also an option of a subscription model. It's kind of similar to what we see with CPAP, where basically a patient is renting their device for a period of time, and then from then onward is only paying for the resupply for it. And so that's an option with the iNAP as well, where a patient has a monthly essential rental fee for the device and get access to it there. And then once the device is paid off, then they're only paying that small fee for the replacements. And similar to CPAP, the FDA says that if there's silicone involved and it's touching the patient, some things need to be replaced on a regular basis. So that would be everything from the saliva pads that go inside the container to the tube that connects the device itself, the pump, to the mouthpiece, and then of course the mouthpiece will get replaced on a regular basis as well.
Okay. Question, Parker? More questions from the audience?
Yes, let's see. Okay, so I know you talked on how you introduce it to your patients, set those expectations, but from a standpoint of the preparation from what it will feel like or what their experience is with getting the iNAP. So I guess working with Somnix is what this question is asking. So what do you prepare your patient for in regards to how their experience in onboarding and those steps would be with working with the iNAP team?
Yeah, so we do all our own onboarding ourselves in my clinic. So, they know us, they know our faces, they know our voices, and so they're familiar with us, and so we're able to walk them through that. But of course, for patients that are getting their device from Somnix directly, there is an onboarding process by the Somnix team. So when they get their device, they'll have a virtual encounter with a representative from Somnix to kind of walk them through the initial use, the maintenance of it, how to set up the app, how to utilize it effectively. If they have a companion device like an oximeter, how can they pair that with the device? All of which is relatively simple, but it's always good to have somebody walk you through that in the first place, as well as sort of tackle frequently asked questions, help prepare them for potential issues they may face, like anytime you put anything in the mouth, we're going to have some excess salivation. So how does the patient get adjusted to that? Some people have fears that what if I salivate too much? So I'm going to fill up the container and it's going to overflow and it's going to spill onto my pillow, whatever. And so addressing those kind of concerns with patients, all that can happen, either in the clinician's office, if you're experienced with it or distributing it yourself, which is what we have, the model we have at my practice, or that can also be done directly by Somnix with the patient. And so any prescriber, who's getting their patient set up with this device doesn't necessarily have to be able to answer every single one of these nuanced questions a patient might have, because the team at Somnix is able to take care of that.
We do have some question on the meeting chat as well, I think.
Yeah. So how often do you request that your patients return to you once you start them on this device?
So we follow, basically an identical process as we do for any intervention, with sort of CPAP being the typical one. So we like to see our patients back for we call a rapid follow-up. So some point within the first 1 to 2 weeks after first getting their device, and then we want to see them, at some point in those first 30 to 60 days or so as well. And and then ideally within another 3 months or so after that. And then if they're doing fine, then we'll spread out the visits to about once a year or so. But we try to have at least 2 to 4 different visits within those first 90 to 100 days or so, because just like with any intervention, just like with any medication, if somebody's going to struggle, if there's going to be a problem, it's most likely to occur relatively early. And so we want to be able to catch that issue as quickly as possible, address it, and help get the patient set up for success as soon as possible.
Okay, I see.
Olivier, do you want to answer this next one?
Yeah, I see a question about cost and insurance approved and out of pocket. So because it's a new device, it hasn't been yet cleared by insurance, even though we're working on getting it and talking to CMS. We already have a HIPAA code that has been assigned to us. Do not use them right now because you won't get a positive response on your claim. So the cost of the device, as Dr. Lennon mentioned, there's like 2 models. There's either the out-of-pocket upfront payment, it's $14.99, and it comes with 3 months of supplies. And there's also a subscription model, we call it a membership, where for $99 a month, a patient can start with a device right away. And they pay $99 a month for 30 months, and that includes the automatic shipment every 3 months of all the supply they need at their doorstep. So this is a cost. There's also a return policy. The people who pay upfront, they have 90 days if they feel it's not working out for them to return the device. We take it back. We reimburse them minus restocking fees. And for the subscription model, we ask the patient to be on the treatment at least for 3 months to try it, and we help them, we coach them. And really, if they cannot be successful with it, they don't like it, then they just return the device to us, and then we just stop the subscription, and that's it. There's no more question asked.
Right, so I think that's really key, whenever you're talking about a treatment where the patient's going to have to pay out of pocket for something is always the concern, what if I don't like it, right? So what if I'm disappointed or, and so I think that's a big fear for a lot of people, especially when you're talking about, something that's, more than just a few dollars. And so it certainly brings a lot of peace of mind for people where, they know that they have plenty of time, to use this, to get adjusted to it, to decide for themselves whether they want to move forward with this or not. Certainly I know our CPAP patients are peeved when, they might use it for 89 days and then turn it back into the DME, and they're not getting their money back, right? And so I think that the fact that, using a device like iNAP, if for whatever reason the patient doesn't want to continue with it and they return it within that window of time, they will get their money back. You don't see that in most other instances, but that's just one other way of helping to make that process a little bit smoother, because as of right now, this is not a device that insurance is reimbursing for directly. That being said, of course, it is a medical intervention, and so if somebody has a health savings account or flex spending account, that this expense is eligible for those things as well. And so it's just not something that their health insurance is going to reimburse them for.
Yes, thank you. We have like 5 minutes left, and so there's still a couple of more questions. One from Laura McFarland. Are there sleep centers incorporating iNAP as a treatment option during polysomnography? I don't know, are you doing that in your sleep clinic? Are you having, while the patient is under PSG, using an iNAP and maybe changing the pressure setting?
No, not on a regular basis. I think we've had maybe 1 or 2 cases where somebody who has been on their iNAP for a couple of months and is coming in for a therapy study to determine the degree of improvement they've experienced with, and whether or not we need to make any adjustments to their settings or not. Where they've come in, they had a baseline PSG, now they're coming in for a repeat PSG. Most of the time, it's home study and then repeat home study when somebody's using an iNAP. But we're not sort of doing this on a regular basis, or even for the patients that have come in, we're not titrating the device while they're using it. I'm not aware of the exact interface they had for that titration study, how they were adjusting it sort of live. What we have through the dashboard is the option of, again, off-label, changing the pressure setting, basically hitting confirm, and then when the patient next opens the app, they get a little prompt saying, hey, your doctor has made some adjustments to your settings, do you accept? And then the patient will click yes or no. So I'm not sure even how we would be able to do that on the fly during a titration study of adjusting the pressure up or down. I'm sure there's a way that we can talk about to get that done, but that's not something that we're doing routinely.
But it is feasible. But the good news is the fact that the whole interface is so small, and pretty much what you see when the patient is sleeping with it is just like a little tube. It's completely compatible with a PSG. So it doesn't interfere with a cannula, with whatever sensor you put on the
oral thermistor, yeah.
And the thermistor and everything. So sometimes we can have that problem with a full mask CPAP. There's no such problem with iNAP. It's fully compatible with a full PSG. And I think we do have a question about excess drooling. Would this device be appropriate?
I don't see why not. I mean, if anything, it would sort of help with that to some extent, right? I mean, because basically what this device is doing is just suctioning from the oral cavity into the container itself. Of course, the where in the airway this suctioning is important, right? So when you go to the dentist and they have the dental suction, that's really down towards the base of the mouth. The iNAP is suctioning between the tongue and the palate. So if there's a lot of saliva in that glossal, retroglossal area, then it will certainly be able to pick that up. But it's not necessarily going to be suctioning up any saliva that's pooling at the bottom of the mouth. And similar to what we see with other intraoral devices as well, is that any increase in salivation that occurs is always temporary. And so typically with our patients, we see within a matter of days, whatever excess salivation they may have is already gone away. And so this is not certainly something that is going to be increasing their salivation over and over and over again every single time that they use it. And so if somebody already has a lot of salivation, they're concerned that this is going to exacerbate that. Even if it does, which of course not everyone experiences that, even if it does, it would only be temporary. But based on the nature of the device, whatever salivation could be there that would otherwise be spilling out of their mouth if they're drooling on their pillow or something like that, that this device will actually suction it up, and put it cleanly into the container.
Okay, so I think we came to the end of this session. So again, I apologize for the glitch that we had at the beginning. Promise next time we'll fix that. So that was the first one of our webinar series. Thank you so much, Dr. Lennon. We'll let everyone know when we schedule the next one. It should be in the next couple of months with another topic evolving around, of course, the iNAP and patient experience and physician experience as well.